I am Dr. Fatima Khan, and today we are going to talk about brain hemorrhages. There are two different types of brain hemorrhages, the extra-axial brain hemorrhage and the intra-axial brain hemorrhage. The extra-axial brain hemorrhage occurs when there is bleeding within the skull bone but outside the brain tissue. And there are three subtypes: epidural hematoma, the subdural hematoma, and the subarachnoid hemorrhage. Now coming to intra-axial brain hemorrhages. So intra-axial hemorrhage occurs when there is bleeding within the brain tissue. And there are two subtypes, the intracerebral hemorrhage and the intraventricular hemorrhage. Now let's discuss the extra-axial brain hemorrhages in detail. First of all, we're going to talk about the epidural hematoma. Now, an epidural hematoma occurs when there is bleeding between the skull bone and the dura mater. An epidural hematoma typically occurs secondary to skull fracture involving the terion and subsequent rupture of the middle meningeal artery. Now, what is terion? Terion is an area located on the side of the bony skull in the temporal region where four bones meet, and these bones include the frontal bone, the parietal bone, the greater wing of the sphenoid bone, and the temporal bone. The symptoms usually occur within minutes to hours after a head injury and indicate an emergency situation. A lucid interval is especially indicative of an epidural hematoma. Now, what is a lucid interval? If a patient loses consciousness at the time of impact, a lucid interval is a period of alertness, a temporary improvement in the patient's condition, followed by rapid deterioration back to unconsciousness. Other clinical features of a patient with epidural hematoma include confusion, dizziness, headache, nausea, and vomiting. A non-contrast head CT scan shows a biconvex or lens-shaped mass not crossing the suture lines. Only symptomatic or large hematomas need to be treated, and they can be managed with intubation and hypoventilation, mannitol, and surgical drainage. Complications of epidural hematoma include seizures, permanent brain injury, and rapid hematoma expansion under systemic arterial pressure can cause herniation of the brain and cranial nerve 3 palsy. This is a non-contrast CT scan of the head showing a right epidural hematoma with midline shift. The midline shift occurs because the bleed is exerting a mass effect. Now let's talk about subdural hematomas. A subdural hematoma occurs when there's bleeding between the dura mater and the arachnoid mater. And it occurs because of rupture of the bridging veins. The most common risk factors of a subdural hematoma include head trauma, elderly and alcoholics because of cerebral atrophy and an increased fall risk in these populations, infants because their blood vessels are thin-walled, and lastly, anticoagulant use. A subdural hematoma can be acute with an onset about 1 to 2 days after injury. It can present with an altered level of consciousness and symptoms of an increased intracranial pressure, such as headache, nausea, vomiting. A subdural hematoma can also be chronic, with an onset about weeks after injury, and it can present with headache, confusion, somnolence, lightheadedness, focal neurologic deficits. A non-contrast CT scan of the head shows a crescent-shaped mass which crosses the suture lines. Now let's discuss the treatment of subdural hematoma. If the patient is on anticoagulants, we will ask them to discontinue the anticoagulants. Secondly, symptomatic or large hematomas can be managed with intubation and hypoventilation, mannitol, and surgical drainage of the hematoma. The complications include brain herniation and seizures. This is a non-contrast CT scan of the head, and it shows a subdural hematoma with midline shift. This shows an epidural hematoma and a subdural hematoma. An epidural hematoma is a convex-shaped mass. It looks like a pie. On the other hand, a subdural hematoma is concave-shaped mass, and it looks like a banana. Now let's discuss the subarachnoid hemorrhage. A subarachnoid hemorrhage occurs when there is bleeding within the subarachnoid space. The subarachnoid space is located between the arachnoid mater and the pia mater of the brain. This space normally contains the cerebrospinal fluid. The most common cause of bleeding within the subarachnoid space is rupture of an aneurysm, such as Berry aneurysms. These aneurysms occur at the circle of Willis, with the anterior communicating artery being the most common site. The other risk factors of subarachnoid hemorrhage include trauma, hypertension, smoking, moderate to heavy alcohol use, family history, use of sympathomimetic drugs, and arteriovenous malformations. The subarachnoid hemorrhage is characterized by sudden onset of thunderclap headache, focal neurologic deficits, a brief loss of consciousness, nausea, vomiting, and signs of meningeal irritation, which include neck stiffness, headache, and photophobia. A non-contrast CT scan of the head is sensitive within 2 to 6 hours of subarachnoid hemorrhage onset. A lumbar puncture is required to exclude subarachnoid hemorrhage in patients with a negative CT scan of the head, and xanthochromia on lumbar puncture confirms diagnosis. Xanthochromia is presence of bilirubin in the cerebrospinal fluid, secondary to breakdown of the red blood cells, resulting in yellow discoloration. A cerebral angiography can also be done to identify the bleeding source. Now let's discuss the complications of subarachnoid hemorrhage. Rebleeding can occur within the first 24 hours and is a major cause of death within the first 24 hours of presentation. Vasospasm can occur 3 to 10 days after presentation and is a major cause of morbidity and mortality in subarachnoid hemorrhage and can result in cerebral infarction. Hydrocephalus can also occur because subarachnoid hemorrhage causes obstruction of cerebrospinal fluid flow in the subarachnoid space. Therefore, there is decreased cerebrospinal fluid absorption at the arachnoid granulations. The CSF accumulates within the subarachnoid space, causing hydrocephalus. A subarachnoid hemorrhage can also cause an intracerebral hemorrhage. Bleeding within the brain tissue will lead to an increased intracranial pressure within the brain. This will cause a decrease in the cerebral blood flow, eventually resulting in transient global cerebral ischemia and brain injury. Cerebral salt wasting occurs because subarachnoid hemorrhage will eventually cause an increase in the sympathetic response. This will cause the body to produce the brain natriuretic peptide, eventually causing natriuresis. And syndrome of inappropriate ADH secretion will cause an increase in the ADH production, and ADH will cause water retention, eventually resulting in hyponatremia. Other complications of subarachnoid hemorrhage include seizures, anemia, and hyperglycemia. Nimodipine can be used to reduce vasospasm. Intravenous mannitol and ventricular peritoneal shunt can be used to treat hydrocephalus. In order to prevent seizures, patients can be given anticonvulsants such as phenytoin. And if there is an aneurysm, then craniotomy with aneurysm clipping or coiling can be done. This is a non-contrast CT scan of head, and it shows subarachnoid hemorrhage as a white area in the center. This completes the extra-axial brain hemorrhages. Now we are going to discuss the intra-axial brain hemorrhages. An intra-axial brain hemorrhage is bleeding within the brain tissue. And there are two types, intracerebral hemorrhage and intraventricular hemorrhage. An intracerebral hemorrhage is bleeding within the brain parenchyma. So there can be bleeding within the lobes of the brain, known as lobar hemorrhage, or bleeding within the pons, known as pontine hemorrhage, or bleeding within the thalamus, known as thalamic hemorrhage, or bleeding within the cerebellum, known as the cerebellar hemorrhage. An intraventricular hemorrhage is bleeding that occurs within the ventricles of the brain. Now let's discuss the intracerebral hemorrhage. The most common cause of an intracerebral hemorrhage is hypertension. Hypertension can lead to hyaline arteriolosclerosis. This causes the vessel wall to become more stiff and brittle and more vulnerable to rupture. Hypertension can also lead to formation of microaneurysms. These are tiny bulges in the walls of the arteries, and these are known as Charcot-Bouchard aneurysms. They are most likely to be found on small arteries like lenticulostriate vessels, which supply the basal ganglia. Another cause of an intracerebral hemorrhage is arteriovenous malformations. These are a tangle of blood vessels that directly connect an artery to a vein, and these abnormal vessels can rupture, causing a hemorrhagic stroke. Other causes include vasculitis, which is an inflammation in the wall of a vessel, vascular tumors, example hemangioma. These are benign vascular tumor of endothelial cells of blood vessels. In cerebral amyloid angiopathy, this is a degenerative disease. Here, an abnormal protein deposits in the walls of the arterioles, making them less compliant and more likely to rupture. It can also occur secondary to ischemic stroke. An intracerebral hemorrhage presents with headache, nausea, vomiting, an altered level of consciousness, weakness or numbness in the face, arm, or leg, which usually occurs on one side. It can also present with speech difficulties and vision loss. A non-contrast CT scan of the head can be used to diagnose an intracerebral hemorrhage. Now let's discuss the complications of an intracerebral hemorrhage. An intracerebral hemorrhage puts pressure on the skull, the brain tissue, and the blood vessels. An increased pressure within the brain tissue will cause the brain to herniate. An increased pressure on the blood vessels of the brain will eventually deprive the downstream tissues of oxygen, resulting in death of healthy tissues, known as infarction. Other complications include seizures and hydrocephalus. We can treat an intracerebral hemorrhage by treating hypertension and by surgical drainage of blood. This is a non-contrast CT scan of the head and it shows hemorrhage in the right frontal lobe. The blue arrow indicates vasogenic edema. The red arrow indicates right to left midline shift, and the presence of sulcal effacement suggests diffuse cerebral edema. An intraventricular hemorrhage is bleeding confined to the ventricular system of brain, and it most commonly occurs secondary to another hemorrhage, such as a subarachnoid hemorrhage or an intracerebral hemorrhage. And this completes our topic of brain hemorrhages. Thank you.